Good morning, good afternoon, good evening to all of you. Welcome to 6th AFOMP School webinar of 2022. In June 2021, we started AFOMP School in addition to the AFOMP webinars where
Emphasizing real-time related.
since June 2020, we started AFOMP monthly webinars of 1 hour, and there was a demand that on a topic, more detailed discussions and lecture should be there. And then we started from June 2021, the AFOMP School webinars of 2.5 to 3 hours with 3 to 4 speakers on a topic. And in this year, this is the 6th webinar. And thanks to Professor Paul Keall for accepting the invitation from the AFOMP to arrange the AFOMP School webinar. And he has taken up this task, and we are having today 5 eminent speakers to speak on with the topic of democratizing real-time radiation therapy, real-time image guidance, and motion management on conventional linear accelerator. Paul Keall is a well-known figure in the research development, and it should be the involvement of the medical physicist into a development of the technology, the equipment, and also validation of the technology and equipment. So in this AFOMP School webinar, we have 5 speakers, and the first speaker is a very eminent figure. He is the director of the Image X Institute, which is established in University of Sydney, Australia. And I had an opportunity to visit his institute and also discuss with him and his postdocs and colleagues on the development is happening in this innovative lab. So the first talk will be from Professor Keall, Paul Keall, lessons learned from implementing real-time IGRT for prostate SABR in the TROG 15.01 trial. And then the next talk will be from Dr. Chandrima, then Professor Jeremy, Emily, Hewson, and Maegan. And what I will do is, whatever questions you have during this talk, you put on the chat box. I will try to collect all the questions and we will have a panel discussion at the end. But in case any urgent questions are there, we can take up after the one talk is over, and then after that. So first and foremost thing, the first talk will be from Professor Paul Keall, and after that he will take over after his talk is over and introduce the next speakers. So some housekeeping announcement is this: the please mute your microphone and put off your camera so that you get a bandwidth. This AFOMP School webinar is being recorded, and this will be put on the AFOMP website and so linked to the IOMP, and so that you can see any number of times, any time you want to see. Without wasting the time, now I welcome Professor Paul Keall for his important talk and also introducing the other speaker. So the floor is yours, Professor Paul Keall. Welcome for this AFOMP School webinar.
Thank you very much for that introduction, Professor Chougule, and it's a pleasure to be invited to this and to be speaking to you today about a topic that is important to us in Australia, democratizing real-time radiation therapy, and in general in Australia, that there are people in regional and rural areas have got less access to higher technology equipment than those in the cities. And we also know that in different countries as well, that there are quite different access to technology. So one of the goals of our program, focused on real-time radiation therapy, has been looking at how can we use the equipment that we have today to make to be smarter and to be able to deploy that technology. If we're using the same equipment that we have today, then hopefully that the software that we develop can be used to improve treatment at other sites as well. And that's really some of the justification for our work to try and improve access to improved radiation therapy, imaging and targeting technology. I do have some disclosures that are listed here, and I work with a number of companies to help advance some of the technology that we are working on. So democratizing radiation therapy, 1 in 2 people with cancer need radiotherapy, which is 8.5 of the 17 million new cancer cases each year. And this is like a staggering number. And what that means is that anything we can do to make radiation therapy better or cheaper or faster is going to impact many, many patients. And also, radiation therapy is both effective and cost effective. If we look at some data here, this is from some work also performed in Sydney by a different group, and looking at across each of the different cancer types, what is the absolute benefit in terms of local control, and also the benefit of survival of radiation therapy, radiotherapy, and also interestingly compared to chemotherapy as well. And the benefit of radiation therapy is much larger than that of chemotherapy, and much cheaper as well. So in terms of, if we're looking at democratizing cancer treatment in general, radiation therapy is really something we should be advocating for. So overall, this data showed a 23% 5-year local control benefit and a 6% 5-year survival benefit for all patients. And per life year saved, $13,000, and this is much cheaper than many of the drugs for chemotherapy and also for immunotherapy. And there are many different initiatives and groups looking at democratizing radiation therapy and making radiotherapy more robust and more accessible around the globe. There is an initiative, the STELLAR project, Smart Technology to Extend Lives with Linear Accelerators. And this is a collaboration between the CERN Physics Laboratory, the International Cancer Expert Corps, and other groups, looking at how can we make the equipment that we use more robust, more cost-effective, smaller, and be able to be used in harsher environments. Another initiative is from Professor Lawrence Court from the MD Anderson Cancer Center, who got some funding to develop the Radiation Planning Assistant and a web-based automated server, and giving high-quality contouring and planning around the world. And planning systems cost, as you may know, planning systems cost a lot of money. And if this can be made much more available and much cheaper, and also in addition to the planning systems being available, the tools that we use and the protocols that we use were available, then would improve the consistency and quality across the globe. And I think even in the developed and the developing world. So in this work, that there's tools that does either contouring and either simple planning or complex planning. The MD Anderson team has been very engaged around the world with a number of sites in Tanzania and other places in Southern Africa, and looking at how the acceptability, if they use this automated tools, how acceptable are they? And for different sites, that the tool appears quite acceptable as is, and will only get better with time. So I think tools like this will hopefully make all of radiotherapy easier to use and more efficient, require fewer people, and also potentially have fewer errors as well. Another global project is being performed, led by Eric Ford from the University of Washington in Seattle, and they're looking at, well, one of the components with the highest failure rate in modern linear accelerators is the multi-leaf collimator, and depending on access to service, changing a single leaf motor can take quite a long time. So they are proposing and have developed compensator-based IMRT with Cobalt, and using the modern technology of 3D printing to enable the printing of compensators and reusing the compensators because the technology, reusing the compensators then for printing and recycling them, so that there is very, very little loss, and be able to use the 3D printing to treat efficiently and effectively in some challenging environments. So these are other approaches. Something that we are looking at ourselves is that we're trying to help is by using open source hardware and software projects. This is our GitHub repository showing some of the projects that you can access and download if any of these tools are relevant to your needs and your projects. And I think what can you do to help other centers in other countries that are maybe less fortunate, and I think similar to us, to do open source hardware and software, and also to make public protocols, processes, QA documents and scripts because others may need them. So I think democratizing radiation therapy is something that we can all participate in and help with. And what would an ideal system look like? What do we need? And so I think, independent of where a patient is, we would like, for pre-treatment, a tool similar to the radiation physics assistant, auto-assisted prescription, contouring and planning on an approved, cost-effective system, so we can have high quality at low cost. For treatment, we would like efficient, online adapted, real-time, markerless tracking and real-time adaptation on an approved, cost-effective cancer treatment system. Of course, this is much less available than, and a bit further from reality than the pre-treatment tools that I previously talked about. And this treatment is really the space that we have been developing, and a lot of the discussion today will be focused on. And a lot of the interesting things is that the innovations that we're talking about are in software, and software is very scalable, it's very shareable, and potentially cost-effective as well. So that is one of the drivers for, if we can add software to existing equipment, we can hopefully get these to be existing equipment to be much smarter than they currently are, and much more effective for patient treatment and throughput. And automation also drives efficiency and safety as well. So we can hopefully use these tools to treat more patients in less time. So that was the introduction, and just bringing that to one of the trials that we implemented, and this was looking at using real-time radiation therapy for prostate stereotactic ablative radiotherapy. TROG is the Trans-Tasman Radiation Oncology Group. It is similar to the NRG in the US, for those who know that. And this was a trial that we led. So why did we do this? Because of tumor motion. That we know that tumors move when the patient is on the table by coughing, breathing. For cancer patients, there's digestion, twitching, and with this motion, then we can either manage it. If we underestimate the motion during treatment, we will miss the target. If we have large margins, then this is extra radiation that the patient gives dose to the patient that they don't need. And of course, this means collateral damage, and additional dose. Collateral damage means side effects. And there's very strong evidence that improving cancer targeting will reduce the side effects of cancer treatment. So ideally, for democratizing radiation therapy, we would like a tool during treatment such as this, where there are no markers, where we can visualize the target, and our treatment beam locks onto that target and can treat it and directly treat it. This is just an animation, and it's easier to make animations and much harder to implement real-time systems. And this slide is nearly 20 years old now, and this was from the first 4D radiation therapy panel that Astro put together at a conference in Salt Lake City, and looking at all of the changes that are happening to patients during treatment. And these are changes to every patient. So there's a lot of anatomic and physiologic changes that are occurring, and the technology that we have is a long way from being able to adapt to these anatomic changes, let alone the physiologic changes. There is evidence that more frequent imaging and targeting does improve treatment outcomes. A randomized trial from France of 470 patients were randomized to weekly IGRT versus daily IGRT. And if we look at the biochemical recurrence incidence over time, we see that the daily IGRT group had a lower chance of biochemical recurrence than the weekly IGRT group, and they also had lower late rectal toxicity as well. So this really is the double-edged sword, that more accurate targeting does improve both the tumor control and reduces toxicity. No trial has yet been done comparing real-time radiation therapy versus daily image guidance. However, there have been some studies. This study is from Memorial Sloan Kettering Cancer Center, and comparing their experience when they implemented real-time radiation therapy to the prior to what they would have treated without any correction. What they found that for about 10% of the patients, that the dose that the patient received without the real-time radiation therapy would have resulted in a dose distribution that wouldn't have passed their plan QA, which is an interesting way to look at to assess the treatment quality, but further evidence of the need for improved targeting. So in this trial, we were looking at implementing real-time 3D image-guided radiation therapy on a standard linear accelerator. There are many real-time 3D IGRT systems, including CyberKnife, MRI linear accelerators that are available, but these are not accessible to most of us. And what we are looking at is taking the technological advances of these real-time systems and making them available to across all of the 90% of the machines that are installed around the world. And there's a lot of tools that are, we have a lot on a regular linear accelerator with which we can use, we can perform real-time imaging and real-time targeting. We have the KV and MV imaging systems. Sometimes we have respiratory monitoring. And to hit the target, we've got the multi-leaf collimator and the couch, which can also be used for the real-time motion management. And there have been some 2D image-guided radiation therapy implementations, and which have got some advantage, and much better than the previously when we weren't watching the target motion during treatment. But moving to 3 dimensions allows much more advanced technology. So that the technology we implemented in this trial was kilovoltage intrafraction monitoring. And this was really solved by Per Poulsen, who at the time was working at Stanford University. And the question that I posed to him was, how do you determine 3D positions from 2D X-ray images? Because that is the tool that we have. And he solved this by taking the current, if we acquire images during treatment and use the current information plus the prior information to build a probability density function of the location of the target. And we solve that using maximum likelihood. Then we can estimate quite accurately the 3D position of the target. This technology was further expanded upon to allow us not just the position of the target, but also the rotation as well. So this is some of the mathematics that's underpinning the KIM technology, which was part of the trial. And how does this work in practice? During the patient treatment, we keep the kilovoltage beam on. We acquire images of the patients. For this trial, there were markers embedded, and Maegan Gargett later today will also talk about work that we're looking at to perform targeting without markers. Then we do the 2D to 3D reconstruction. So the radiation therapists during treatment see the following information. They see the markers, and so they see the motion. They see the images, and they see the motion of the patient of the in this case the prostate during treatment, both from translation and rotation, enabling action to be taken if the thresholds are exceeded. So this KIM technology was employed in the SPARK trial, stereotactic prostate adaptive radiotherapy utilizing kilovoltage intrafraction monitoring. And this was used to, the primary outcome of the trial was dosimetric improvement. The two fractions with firstly the largest prostate benefit with KIM, where the treatment plan is shown on the left, and a fairly standard conformal treatment plan. When we do monitor the patient motion and intervene, the dose that the patient receives is similar to the plan. And in this case, there was a posterior shift of the prostate, and that dose, the dose moved into the bladder, and so the bladder was overdosed and the prostate was underdosed. Similarly, the fraction where the largest benefit of real-time adaptation to the rectum is shown in the bottom row, and the target, again, that we have the treatment plan. When motion is detected and corrected, the patient dose is quite similar to the plan. Had this, in this case, anterior motion of the prostate not been detected, then the patient would have received more dose to the rectum. This is in a 5-fraction treatment, and which makes the accuracy requirements even higher. Looking at those were the extreme examples, looking across all of the fractions of all of the patients for the PTV D95. If we assume that the 5% dose is something that we would accept as normal variability, then about 1 in 6 fractions benefited from the real-time image guidance. And similarly, looking at there's much more variability of the dose in the normal tissues when we have real-time guidance as well. Dose is one thing, also very important. The most important metric is the patient outcomes. And what we found was for the patient-reported outcomes using the EPIC 26 patient-reported outcomes index, that immediately after treatment, there was a slight dip in the quality of life, though at 12 months, there was no change, no significant change from the start of treatment. And this is actually quite staggering that we can have this therapeutic treatment essentially curing a patient of cancer with no side effects, which is just, I think, says a lot about the potential of modern radiation therapy. We also noted a decline, a continuous decline in the prostate-specific antigen levels, though I do note that one of the 46 patients to date has had a biochemical recurrence. We also had very low toxicity for the patients in the trial, and at 12 months, there were no grade 3 or above toxicities and 2 grade 2 GU toxicities and 2 grade 2 GI toxicities. One of the real benefits of being part of these clinical trials is really the engagement with the patients that we have, and also a multidisciplinary engagement with the treatment team. And I would really recommend, if you can be involved in clinical trials, that it's a very fulfilling part of the role, and very satisfying. And also satisfying are some of the patient stories that we have had. For example, John Frazier, that the trial enabled his family to celebrate their 50th wedding anniversary. And the first patient who loved the idea of having 5 fractions instead of 40, one of the doctors sent a text, the patient 1 has just come in remission and no toxicity. He passes on his thanks. I think this is really the benefit of the real satisfaction and benefit of being able to develop technology that is used. So just to summarize, that the trial that we completed can be, the real-time guidance can be performed on conventional radiation therapy systems. And for the theme of this presentation, for democratizing radiation therapy, means that potentially it can be more widely deployed. In addition to being implemented on conventional radiation therapy systems, it was safely implemented in a multi-institutional setting, indicating that multiple sites would be able to more broadly utilize the real-time image guidance technology, and that this was clinically effective for prostate cancer SABR. And this technology is also that the Dr. Chandrima Sengupta will talk about is also potentially potentially useful for other body sites as well. So I think my time is up here, and yeah, thank you for the opportunity to share some of the work that we've done.
Thank you, Professor Paul, for excellently advocating. We need a technology, and mostly for the cancer treatment, the radiotherapy technology. The technology must be affordable, technology must be efficient, and it must be clinically, trially, it should be proved that it does the good thing. You have run through the technologies and also the clinical trial, and the satisfaction you get out that if you have helped with the technology created to the patient to overcome the dreaded disease, that satisfaction is enormous. So thank you very much for your excellent talk. And then the next talk you will be introducing. But before that, I want to tell to all the participants that this AFOMP School webinar is CPD accredited from ACPSEM. Every hour 2 CPD points, and already to register for the CPD point certificates, the link is provided into the chat box. Please do register yourself so we can provide you the CPD points and the certificates. With this instructions, I hand over the floor to Professor Paul Keall to continue to the next talk and introducing the speaker.
Thank you, and it's a pleasure to announce the next speaker, Dr. Chandrima Sengupta, and she works very hard every day on implementing new technology in clinical trials. She's a postdoctoral fellow at the ImageX Institute at the University of Sydney, and she'll be talking about marker-based real-time image-guided radiation therapy on conventional linear accelerators. And thank you, Chandrima.
Thanks, Paul, for the introduction, and thanks to Professor Chougule for the invitation to present in this meeting. So I'm going to give a brief overview of different marker-based real-time IGRT techniques on standard linear accelerators. So from Paul's talk, Paul has talked about the prostate motion, and we have seen that the prostate can move during radiation therapy treatment. And if we can correct for this motion, we can really get better dosimetric outcome and therefore better treatment outcomes. There's also a number of organs that move during radiation therapy treatment. And if we think about the motion, the prostate motion is really slow and small, whereas, for example, the respiratory motion is fast and large. And on top of that, tumors not only just translate, but they also rotate and deform as we treat the patient. So at any point during a treatment, we do see a combination of all these type of motion. And we want a solution with which we can detect all these type of motion on standard linear accelerators. So what are the tools we have on standard LINACs that we can use to detect the tumor motion? So we have the kilovoltage X-ray imager, and we also have the megavoltage X-ray imager. Now, one of the problems with the X-ray images is that we really can't see the tumor because of the poor soft tissue contrast. So different types of markers are implanted near the patient's tumor, and then they are used as surrogate for the tumor motion. Now, of course, marker implantation means there's an additional cost. It's an extra procedure, so the patient has to come for this before the treatment. And some of the time, this increases the risk of bleeding and infection. But there's also a number of papers that show that the markers improve the tumor targeting accuracy and helps to reduce the treatment margin to the tumor volume. And there are many centers who routinely implant these markers for their pre-treatment imaging. So the markers are already there, and why don't we then use them for interfraction motion monitoring? So what are the aims when we think about real-time IGRT? So there are two main aims. We want to find the cancer as we treat the patient and then hit the cancer. So the first step then is to know where this plant marker position is. And this usually comes from some pre-treatment imaging process, which could be a CBCT, a CT scan, or a 4D CT scan. So once we know the plant marker position, and then during a treatment, we receive the patient images. And the first step then is to process these images so that we can improve the visibility of the markers in the images. So for that, we can apply a number of these methods. And then as you see here, that the input image could be really noisy, but after applying these filters, the image quality could improve. And then the next task is the marker segmentation. So again, there are different methods with which you can segment the marker. So typically for cylindrical or spherical shaped marker, we use a method called template matching, where a 2D template and a predefined region of interest of the current projection is matched, and then a cross correlation coefficient is the map is formed, and then the highest cross correlation coefficient is defined as the marker for that particular projection. And then there are also approaches like the machine learning that one can use for segmenting the markers. So once we know the marker position, then we compare that with the plant marker position, which then can be used to derive the tumor motion. So once we know where the tumor is, then the next step is to hit the cancer, and we have two different components that we can use for that. So we have the treatment couch that we can use for gating or couch tracking. So with gating, the concept is that, say, the patient motion is within a certain treatment threshold. So then we treat the patient, and then if it's outside the threshold, then we stop the beam and shift this couch to compensate for the motion. And then we can also use the multi-leaf collimator to add up to the tumor motion. So Jeremy and Emily will talk more about that today. So the first step, or probably the most simplest step, to do the 2D image guided radiation therapy. So then the idea here is that we get these 2D planar images. The markers are detected from these images, that then the 2D motion can be derived. So there are two main technologies in this space. So we have seed tracker that works on electrolinacs, and then we have triggered imaging that works on variant linacs. And pretty much they work in the very similar way. So in seed tracker, the imaging is performed at 5 frames per second, whereas with triggered imaging, it's applied at an interval of 3 seconds. And both the methods have been clinically implemented and been used to treat prostate, lung, and pancreas cancer patients. So with this 2D IGRT, we are doing better. So we have the 2D real-time tumor motion at any point during a treatment. And different publications show that they improve the treatment accuracy. But what they really do not do is they do not provide the 3D target position or the 60 position, so the tumor translation plus rotation. And therefore, this information cannot be used for MLC tracking or couch tracking. So then the next question is, how do we go from the images to the 3D target position? So we have the 2D image at any point during a treatment, but we also have the pre-knowledge of the 2D images from other angles. So we can use that knowledge to build a probability density function, and the expectation of the maximum value of the PDF provides the 3D target position at any point during a treatment. So there are different methods that can be used to build this 3D PDF function. So there's this Gaussian PDF that can be determined from the maximum likelihood method. And there are also Bayesian approach that can also be used. One of the drawbacks of this method is that we need a learning arc before the treatment to build this PDF. And therefore, that means that's extra time on the treatment machine, and then also additional imaging dose to the patient. So then there's another approach that can be used, which is the Kalman filter approach, where the Kalman filter process distribution is initialized with a population covariance matrix. And therefore, with that approach, we don't really need that learning arc. And then this method iteratively estimates the posteriori function, and therefore it doesn't have to solve all the parameters from this 3D PDF method. And therefore, computationally, this method is more efficient. And there are also other approaches that can be used for this 2D to 3D transformation. For example, the interdimensional motion correlation model that can be used for respiratory motion. And the idea here is that we know that the superior inferior motion is in all directions, and for respiratory motion, press the left, right, and the anterior posterior direction as a function of the superior inferior. So before the treatment, field and function is defined between the LR direction with the SI direction, and during treatment, this can be used to get to the unresolved direction. So this is an overview of the methods that can be used to get from the use the 2D images to derive the 3D target position. So one of the widely used technologies in this space is kilovoltage interfraction monitoring, or KIM. And Paul has talked about the KIM method, so I'm not going into too much detail. But just to remind you what KIM does, KIM reads these kilovoltage images, segments the markers, use this 2D to 3D PDF method to provide the translation and rotation at any point during the treatment, which can then be used for either gating or MLC tracking or couch tracking. So KIM was first used in 2014 when the first prostate cancer patient was treated. And then through a series of clinical trials, we have treated prostate, liver, and pancreas cancer patients. So far, we have treated 152 patients at 7 centers in Australia. So Paul talked about the SPARK trial. I'll talk a little bit about the LARC trial, which is the first 6D liver motion monitoring on standard Linux. So in the LARC trial, the aim is to recruit 46 liver cancer patients. And for this trial, we have clinically implemented KIM on both variant TrueBeam and Electra Linux. And we have treated patients in both in breath hold and pre-breathing. If you look at the average treatment time, this is usually less or very similar to the standard of care treatment time. So this tells us that we can do interaction motion monitoring without adding any extra time to the overall treatment workflow. In LARC, when we treat a patient, we use the gating approach. So if the motion is within a certain gating treatment threshold, we treat a patient. If not, then we manually shift the couch. And so if we look at the number of KIM-triggered gating events, there was at least one gating event per patient. So if we did not have KIM or real-time motion monitoring, this motion will remain undetected. So the KIM accuracy for liver motion tracking was determined against the triangulation method, and the accuracy was found to be below 1 mil and precision below 2 mil. And then ultimately, we want to know how well we delivered the dose, because that's directly related to the treatment outcomes. So here are some of the dose maps for 4 different fractions from 4 different patients treated in the LARC trial. And so if we look at the dose delivered with KIM and compare that with plan, it was much closer to the plan. But then if we simulate a situation saying that if there is no real-time motion monitoring, so we undo the couch shifts that we applied, we'll see that in each of these cases, a part of the tumor volume was underdosed. And summing up the dose over all the fractions for the first 15 patients, we do see that at least 20% of the patients got better dose by 10% to either the PTV or one of the organs at least. So this is quite significant to me, given that we don't need any extra equipment, we are not spending extra time on the LINAC, but we can still achieve better dose results when we do see significant motion present during a treatment. So far we have only talked about using the KV imager for tumor motion tracking. But we can also combine different like other modalities. For example, here we can combine the KV imager with the MV imager to determine the tumor position. So the idea here is that during treatment, we can pair a KV image with an MV image, segment the markers, and then triangulate to get to the 3D tumor position. And the advantage of this method then is that there's no 2D to 3D approximation. So this method was used to treat 110 prostate cancer patients, and the results show that the method had sub-millimeter accuracy and precision. And one thing here is that we know that the markers could be hidden behind the MLC leaves during a treatment. So in these plans, the plans were made so that at least one marker can be seen from all angles. So the next method is the cosmic method, where the idea is to combine the KB imaging with the external respiratory signal. So what is done here is that from the pre-treatment data set, model is built and a function is defined so that the internal motion can be expressed as a function of the external signal. And then during treatment, only the external signal is acquired, and using the model, we can get the internal motion of the tumor. And if needed, then intermittent KB imaging can be performed to update this model during the treatment. So this method was used for 12 liver severe patients and was validated against the Calypso system. And the results show that sub-millimeter accuracy and precision can be achieved with this method. So this method was further extended to include rotation in this paper and was tested for 6 lung severe patients. And they also tested that if you, for example, increase the KB imaging update interval, say from 0.1 second to 30 seconds, what sort of accuracy or precision we can achieve. So the results show that if you increase the imaging update interval, that increases the motion estimation error. But say even with this 30-second imaging update interval, the translational motion accuracy and precision was sub-millimeter. And for rotation, the accuracy was below 1 degree and precision was below 2 degrees. So this method, because the imaging update interval is, it's not a continuous KB monitoring, so it's still sort of less accurate compared to, for example, the Keall technology, where we are continuously acquiring the KB image. But it's more accurate than the, say, the external respiratory signal alone. And this method can be used for respiratory motion, but for example, if there's a so the advantage of this method then is that we can still monitor the 6D motion of the tumor, but we don't need continuous KB monitoring and therefore less imaging dose to the patient. So here is a comparison among different technologies used to monitor the tumor motion. So the first one is the prostate motion measured by the Keall technology, then the prostate motion measured by the KBMD combination, and then the liver motion measured by the cosmic technology. So what we see here is that common to all these plots is that there was a systematic shift in the patient motion between the CBCT and the actual treatment. And so without this real-time monitoring, this motion will remain undetected. And if we look at the consequences of these on the dose, we'll see again that with real-time monitoring, the dose is close to the planned dose, whereas without real-time monitoring in each of these cases, part of the tumor volume will be underdosed and one or more organs at risk will be overdosed. So this shows that if we use different type of technologies, there could be different accuracy or precision, but if there is motion present during a treatment, real-time monitoring can improve the dose as compared to no motion tracking. So we have talked about different technologies where we have we get the KB and MD images, and one of the challenges that we come across is the correct segmentation of the markers in these images. The images could be really noisy, and there could be other challenges like there could be some surgical clips and other sort of structures that may look like a marker. So at University of Sydney, we are developing a deep learning framework so that we can better segment the markers. And then also ultimately we want to have the smaller markers. So because that means less toxicity to the patient, so better treatment outcome. So the first step of using a deep learning method is to train the model. So the idea here is that, for example, we have a number of layers and each of them extracts different features from an image. So for example, when we train this model with an image, with a marker, the model knows this is how to identify a marker. And then say we then say this is a background, and then the model knows this is how to identify a background. And then say for a fluoroscopic image, so these are the markers, so these are the positive sub-images, and the rest are the negative sub-image. So we train this with both CBCT images and KV fluoroscopic images. And to give a number, how many images we need, so we trained our model, one of our models, with 30,000 positive and 30,000 negative sub-images. And once the model is trained, we evaluate the performance on some unseen data set. So here are some examples of our deep learning model working on some of the clinical trial data that we acquired during different clinical trials. So here you see the prostate images, they're really noisy and it's very hard to see the markers. Here is the lung motion, a very noisy sort of image, and the markers are arbitrarily shaped. And for pancreas, the markers are usually smaller than the typical markers that's been used for prostate or liver treatments. So when we applied our deep learning method, we see that the markers are still well tracked. And if we quantify these results against either the triangulation method or against some manual segmentation, we do see that the marker segmentation in the 2D plane of the imager was all within 1 mil. So that's within the clinical tolerance. So given that the method was working well on the KV images, we extended these to MB images. So marker tracking on MB images in general is more challenging because of the poor contrast. But if we can make it work, then that means, and if we can use the MB imager, that means there would be no imaging dose to the patient. So we applied this, so we trained a deep learning method to track the markers in the MB images. And here is an example for one of our prostate data where, as you see here, that the markers are tracked with the model. So quantifying these numbers for the prostate data for 20 prostate cancer patients, we do see that the accuracy and precision was within 1 mil. So in the future, we plan to extend these to pancreas and other targets. And so we also plan to apply the deep learning method for lipidol tracking. So the idea here is that if we can train a deep learning model with some patient-specific deep learning model to track the liquid fiducial markers from the pre-treatment data set, and then during treatment, we can use the model to track the markers. And one of the applications for these is lipidol tracking for liver cancer patients, where some of these patients receive chemotherapy drug, which retains in the liver even after 11 or 12 months, and can be seen in the X-ray images. So, and we plan to do this test this for 50 liver cancer patients. And if this works, then for these patients, we don't have to implant markers, as I talked about the implications of implanting markers. So this is the very last thing that I'll talk about, that we are developing all these technologies, but how do we know that they're working well? So we need some quality assurance devices that can assure that, well, it's working well and within the tolerance. So we have seen that the tumor can move in all 6 degrees of freedom. So 3 degrees of translation, 3 degrees of rotation. But all the commercially available devices, they can only do 5 axes of motion. And the other sort of problem that we have with this is that, for example, with the Hewson platform, it has very limited angular flexibility. So it can only move in the left-right direction between +3 to -6 degrees. Whereas in reality, for example, for lung and prostate cancer patients, we do see motion up to 45 degrees. So we really need a device that can replicate the actual patient-measured motion traces. So to address this problem, we developed a robot-based quality assurance. So we developed a robot-based quality assurance device. As you see here, a robotic arm is holding a phantom, which has markers implanted in it. And then we also developed a software interface that can send 60 motion traces to the robot that can perform the motion. So for our quality assurance test, this is our ground truth, and we compare our technologies, for example, KIM, with these robot motion traces. So the software and all the phantom design are available in this GitHub link if you want to take a look. And then we applied this method for this device to for quality assurance of KIM in 2 multi-institutional clinical trials, for quality assurance of service guidance systems, and for dose measurements. So that brings me to the end of my talk. So we have seen that there are different methods that are available for real-time tumor motion tracking, and it's very much possible to track tumor motion on standard Linux. And different results show that this improves the treatment accuracy. Nevertheless, we should be trying to have technologies with which we can track smaller and easier to implant markers, because that means better treatment outcomes for the patients. We have also seen that different imaging modalities have their own pros and cons. So ideally, we would like to have, we should take advantage of different imaging modalities so that we can provide the optimal treatment to a patient. And I think Paul discussed this very well. So to make things more widely available, one of the things is to make things more sort of software solutions where that's possible, and making treatment workflow more automated so the entire thing is more efficient and less time consuming. And the future work should continue to improve different aspects of the tracking method, investigating whether we can use liquid fiducial markers and markerless tracking where that's possible. And yes, as Paul said, that making the clinical trial data and the codes that we are writing every day, making that open source so that everyone in the community can really use the resources. So we have published, as Paul said, some of our codes on the GitHub. So here is the QR code if you want to take a look. And yeah, that's all from me, and thanks for listening.
Thank you very much, Chandrima. And one of the questions that came up in the private chat, how much additional time does the IGRT take now, and are there ways to improve the automation? Because like a challenge, you know, IGRT does add time, and if you've got a lot of patients to treat, then how do you balance that?
Yeah, so from my point of view, I'm using KIM. So what I see, the extra time that comes firstly from the learning arc that KIM means. And there are many solutions that you can use really to replace the learning arc with another solution. And the other thing that always comes up is the gating method, where you have to shift the couch. That for every couch shift, it takes around 3 to 4 minutes. So I guess like if we can do MLC tracking, that could like reduce that time as well. And then of course, like making the entire thing more automated, like when you say pass the data from treatment planning system to KIM, if we can make those steps more automated, write scripts to do those things, that would also make things, I guess, less time consuming.
Yes, now I agree. I think that there's a lot of opportunities for automation. And you mentioned MLC tracking. So that is a good segue into the third speaker of this session. And the third speaker is Associate Professor Jeremy Booth, who is the Director of Radiation Oncology Medical Physics at the Northern Sydney Cancer Centre. And he's really been a pioneer in implementing some of these first-in-human clinical trials, where this real-time image guidance technology is applied to patients. So Jeremy, we look forward to your presentation on the clinical implementation of real-time beam alignment with MLC tracking.
Thank you very much, Paul. So we're moving now from what we've seen to date, which is real-time IGRT, being able to see the target and see the organs at risk, to real-time beam target alignment with MLC tracking as one example. I will run through some of the clinical reasoning today. I'll run through a technical review of some of the ways that we can align the beam to the target in real time, apart from MLC tracking. And then we'll share our experience locally at Royal North Shore with lung cancer tracking, our clinical experience with that research system developed at the University of Sydney, some of the lessons learned along the way, and some of the next steps. So I'll start just by explaining where I'm from. I'm from this cancer centre shown in the picture here. This is Royal North Shore Hospital, and our cancer centre is a full variant unit. We're quite small. We have 3 linear accelerators. We have a medium load of patients, and staffing profile is given here. You'll notice that we are fairly rich with staffing. So we have 9 oncologists, 9 medical physicists, and 30 radiation therapists. In Australia, it's the radiation therapists that are performing the lion's share of treatment planning and, of course, operating the treatment machines. At our hospital, we see ourselves as an early adopter. We have a role in teaching with the varying medical systems. We also teach into the university where Paul is based. We have a number of research collaborations, including the University of Sydney and Varian, which we're very grateful for, and which has enabled much of what we've done. So for a long time, we've had a research relationship with Varian Medical Systems. We've been a beta test site a long time ago, and we've developed a number of systems, or at least done the initial testing on a number of systems a while ago, leading sort of to more recent times where we have been an early adopter of some of the commercial systems such as IMRT, SBRT, volumetric imaging, and more recently automated planning with the rapid plan system here, and also with the ethos system. So the real-time adaptive, what we're referring to here is the ability to adapt our radiotherapy delivery to account for intra-treatment anatomic change. So these are changes that are occurring during treatment, such as respiratory motion or deformation or other types of motion. So the first element there is to obtain that real-time position, and we've heard a lot about that today. That's real-time IGRT. These systems will take a certain amount of time to process and adapt the treatment. So we need to predict into the future a few milliseconds, the amount of time that we might need to activate the machine to adapt. We then adapt the machine, the couch or the beam, and then we repeat this cycle. So this is occurring during the treatment, and we're updating our localization during the treatment. I'll show some more graphics on this. So we've seen this already. So we have the dedicated systems for real-time IGRT and real-time target tracking. And what we're really looking at achieving here is to obtain the same level of accuracy on our standard LINAC platforms. So these are the real-time IGRT methods, some of them. So the clinical driver, so why would we want to do real-time adaptation? I think it's quite well demonstrated by the video here showing a lung lesion moving with respiration, and in synchrony with that is a dose distribution that's also moving. So in this case, the multi-leaf collimator is linked in a way to the lesion. So we're tracking the lesion motion, and we're mimicking that with motion of the MLC. So delivering the exact planned dose is what we want to achieve with MLC tracking and real-time adaptation. So this provides a big safety loop between the motion and the delivery. It's an automated process, which means it's a very efficient process, and it means that it does improve the consistency of the deliveries. And it also enables us to shrink our margins, which reduces the OAR dose and provides a nice compact dose concentrated on the lesion itself. I have other examples. So from the literature, we can see for the CyberKnife system for lung tracking, for the Vero system and for MLC tracking, each of these systems reduce the PTV up to about 50%. So significant reductions in the PTV volume, and this also translates to reduction in the mean lung dose. So we're guiding towards safety then for retreatment, for large tumours, for central tumours, and also potentially enabling higher target doses where required. If we move over to an example of motivation for liver SBRT. So in liver SBRT, quite commonly, and this is a simulation study that we've performed, that the target dose might be 50 gray in 5 fractions, but that is constrained by the normal liver tolerance. So depending on the size of the lesion within the liver, we might not be able to deliver the full target dose. So in our simulation, we looked at 20 recent cases of liver SABR at our institution. We found that 13 of these 20 had been constrained and required a lower target dose. When we simulated the delivery with real-time adaptation, so that could be gating the treatment, or that could be delivering with MLC tracking or some sort of target adaptation, 11 of those 13 recovered back up to the full target dose. And even further target dose escalation may have been possible. So, and then if we look at an example for prostate cancer, so we have a treatment plan here, quite a bespoke treatment plan where we've delineated regions within the prostate that require boost. We've got urethral sparing in here as well. So this is a common dose painting. During this treatment, there was a large shift up to over 1 centimeter during the first arc. You can see in the middle a motion trace of this of the prostate in this case, where we have a very large shift. If we calculated or estimated the radiation dose that would have been delivered given this amount of target motion, you can see the image on the right. So in this example, the boosts are no longer receiving a high dose. The prostate itself is not receiving completely the target dose, and there's an additional hotspot in an area that wasn't desired. However, if we were able to treat with MLC tracking, which we were able to in this case, the delivered dose that we received looks very similar to the treatment plan. So we're able to deliver a dose-painted bespoke dose distribution under the forces of motion during treatment with MLC tracking. So now I'm going to just sweep through some of the existing technologies that are available to improve this beam target alignment in real time during treatment. And some of the points of difference, if you like, between the systems include the types of information that they're working with. So that might be a point that is a surrogate of the tumor position, for example, a fiducial, a volume, the shape, also whether it is a target or whether we're looking at the motion of the target or the OAR, and also the frequency of information coming into our loop. So there are many adaptation methods. So the first that I'll run through today is gating, which is the most well used, and then there are the others which I'll go through in time. So we look through this historically. On the top, I have the major commercial milestones for real-time adaptation, and on the bottom, I have the research investigations in this area. And you can see that the top of the curve is really dominated by the CyberKnife system, which is a robotic LINAC, which has been providing real-time adaptation for over 20 years. More recently, there was the Vero system and the RADXact system, commercially available systems that provide real-time adaptation. Under the curve, we have the first gated systems, which were in the late 80s. And then moving along to the 2000s, you can start to see some of the multi-leaf collimator tracking research, so that the first concept paper proposed by Keall was about 20 years ago now, and followed by the feasibility of couch tracking, some phantom simulations, and then the first MLC tracking prostate treatment was 2014. More recently, the Unity MRI LINAC system in a research capacity has been demonstrated to be able to implement MLC tracking as well. So looking back at what we all know and hopefully are able to actually do is gating. So gating is where we stop the treatment beam when the target moves outside a predefined tolerance. So we have a real-time IGRT system that is able to monitor the motion, and we turn the beam off, if you like, and potentially reposition the paper, the patient, and then we continue our treatment with the patient realigned in alignment with the beam. So there are many examples through the literature. The first experimental system that I'm aware of is the RTRT system from Japan. More commonly these days, it's the RPM system, and also driven by surface guidance systems, which seem to be emerging at the moment. And this has been around for a long time. There are task group reports and plenty of literature about how to implement a gating system, which is a very effective way of real-time adaptation. The predominant commercial system is the CyberKnife. So this is an old picture, but the system has dual KV and images and an optical system. Has a robotic arm that synchronizes with the targeting of the detected motion, and it creates a motion model that enables it to track the motion without requiring additional X-rays. So the more recent innovations there is that it does not require fiducials in all cases, particularly for lung cancer and some of the other indications. Couch tracking has not reached the patient just yet, but it has been shown to be a feasible way of adapting the beam target alignment. So in this scenario, the real-time IGRT system would detect internal motion, and then the couch would adapt in real time to synchronize with the internal motion. So this has not been commercialized yet. The Vero system used a gimbaled tracking system. So it also had two dual KV X-ray systems and an optical surface scanner. It tracked with the gimbal ring gantry. So the gantry itself sort of pivots, if you like, forwards and backwards to realign the beam. If you look very closely in that image, you can see that the beam is sort of moving superior and inferior based on the gimbal of the linear accelerator. So it also uses a motion model for correlation between the external and internal motion. This was a fantastic system, but unfortunately is no longer in production. That brings me over to multi-leaf collimator tracking. So this is a system where we have a multi-leaf collimator that adapts its shape to synchronize with motion. So it's a real-time optimization of the leaf position. So the implementation that we've deployed, which is a research implementation, calculates in real time an optimization between the underdose and the overdose in the situation where the lesion is known to have moved. And this also MLC tracking also presents the unique ability to be able to track deformation and multiple targets. So you can see in the image center that we're tracking with the MLC, and the arrows there are changing dimension, and they're all potentially different. So that's a deformation vector field that we're able to track to, so deformation. And then on the right, we have a simulation of a prostate and node. So we have two targets moving separately, independently, and the multi-leaf collimator is able to track these. So the basic data flow of a multi-leaf collimator system, particularly this is the research system that we used in the clinical trials at our hospital, was that the motion was being tracked using the varying calypso system. So this localizes the lesion, or the beacons, as a surrogate for the lesion 50 times a second. That position is fed into a multi-leaf collimator tracking system. So it receives the position, and then it predicts where the lesion will be in 200 milliseconds in the future, which is about the processing time. We re-optimize the aperture, adapting for motion, and then we send that new MLC shape to the MLC, which then positions itself in the predicted position for the lesion to move into that position. We also collect dynalogs, which are the log files of the variant system, to be able to record where the leaves did move into the correct position, and also enables us to calculate the radiation dose that was treated to that particular patient. You can see in this case, it's not a variant true beam. This is a variant clinic, which has a slightly different multi-leaf collimator tracking computer that we interfaced with. So we haven't yet demonstrated on the TrueBeam platform. There's also the MRI guided MLC tracking, as you imagine. MRI is a very nice volumetric image and high contrast, high soft tissue contrast. So we're able to see the lesion and the surrounding organs at risk quite nicely in MRI in real time. And there's extremely quick development of the MRI imaging from 2D to 3D and 4D. So the real-time volumetric or real-time 2D imaging in multiple planes. So I've got an image here showing Martin Fast. So Martin's currently at Utrecht. While he was based at DKFZ and the Marsden, he developed an algorithm that does track the MLC with deformable targets, and that has been implemented on the Elector Unity in that research setting. The great potential, I guess, looking forward, if we look beyond deformation tracking, is the idea, if you like, of real-time functional imaging and real-time tracking of function. So we then also have the RadExact system. So RadExact is sort of the modern version of tomotherapy, I guess, also from the CyberKnife company. So this system is on a ring bore gantry, so it's enabled to rotate very quickly. It has a binary multi-leaf collimator in there. So that the RadExact system detects motion from the KV images and surface, very much using the synchrony, the CyberKnife synchrony system on a standard sort of linear accelerator framework. And it adapts to motion using the jaw, the binary MLC, and the couch in a sort of combination there with a very small latency. So the status of multi-leaf collimator tracking, then these are slides referring to the University of Sydney research software that we used in a research trials with various medical systems. So the initial concept was tested And then we treated our first patient for prostate cancer. This was a long course treatment back in October 2013 using the Calypso system. So with that system, we treated 28 patients. We then shifted our attention to treating lung saver patients, and we treated 17 out of 20. So the reason that we treated 17 was that we met the primary endpoint at that time. So we were only required 17 to meet the primary endpoint. So that again was with Calypso guidance. You can see the Calypso system in the image there. So the challenge here was that it was respiratory motion. It's quite different to prostate motion. So in this case, we did have the prediction filter turned on. And then around the same time, we also treated prostate SABR. This was one of the ways we implemented SABR in our department. We treated 10 patients, and the difference, the key sort of next step here was that we used the KIM system. So there's no Calypso here. This is using just basic gold seeds in the prostate and using the KIM and all standard hardware and the KIM software linked into the University of Sydney multi-leaf collimator tracking system. So that also completed in July 2018, so a little while ago now. So I'd like to talk about LightSaber. So LightSaber is the trial name for our lung tracking trial of multi-leaf collimator tracking. So this was a phase 1-2 investigator-led trial. It was a partnership between the University of Sydney, Very Medical Systems, and Northern Sydney Local Health District, which is the broader health district where our hospital is based. It was a single-arm study, so all patients received multi-leaf collimator tracking, and then we simulated the treatment that they would have received without multi-leaf collimator tracking using an ITV-based approach. We sought to, we thought we needed 20 patients to prove our endpoint, which was that 95% of the treatments were delivered without software malfunction, which showed that the system worked. We targeted stage 1 lung cancer, and the patients had three radiofrequency beacons implanted near the tumor. So this is the Calypso system. You can see a picture of the beacons. They're a little bit larger than the gold markers that you might have in prostate cancer, but they do emit this radio frequency that allows them to be detected by the array panel with very high accuracy at very high frequency. So the summary of the outcomes was that we treated 17 patients before we proved our primary endpoint. We had a mixture of primary and patients with metastases. The lobe where the lesion was varied. The most common fractionation was 48 gray in 4. We had a couple of central lesions where our clinicians at the time preferred 50 and 5. Most of the patients were set up supine. Some of the patients were treated prone, and there was one patient we treated lying on his side, so that was quite unusual. It was mainly limitations of the Calypso system and how far the beacon can be from the chest surface required us to treat prone and on their side. And then the tumor motion that we observed was on average about 1 centimeter, with a maximum up to about 2 centimeters peak to peak. Yeah. So I'll just run through the approach that we took for this clinical trial using the research software. The first step was to implant the markers, the radiofrequency beacons. So this was done endobronchially. You can see an image, a snapshot KV image here, showing the markers being implanted into the lung around the lesion. And then you can also see a maximum intensity projection there that sort of just demonstrates that there is motion occurring as the patient is breathing while we're implanting these. We then performed the treatment planning. So these patients were all treated with VMAT. We had standard sort of dose constraints. And then we created two plans, a multi-lead collimator tracking plan, where we contoured the GTV at end exhale. And then we added 5 millimeters to create a PTV. This was compared, so that's the plan that we treated with. This was compared against what we would have standardly done, which was to contour the GTV on all phases. The union of that is the ITV, then we expand a further 5 millimeters to the PTV. As a research system, we had special ethics approval to do this study. It was a research system that controlled the beam delivery. So there was a significant amount of care that we put into the quality assurance and time spent. I had a PhD student working on this that spent a lot of time. At the time of treatment, the beauty of the Calypso system is that once the patient is lying on the couch, you align them in the room to the Calypso beacons in real time. So when the treatment staff leave the room, the patient is pretty much aligned. We then, for the purposes of the study, we confirmed alignment with the cone beam CT, as shown here, and we matched up the real lesion and the volumes, and we also obtained some fluoroscopic X-ray images just to visualize the amount of motion that we were seeing, and to visualize that the lesion was moving in synchrony with the Calypso beacons, because in our implementation here, the MLC is actually following the beacons, the motion of the beacons. We then delivered treatment, and we collected the MV portal images that you can see here, showing the multi-leaf collimator adjusting the fluence and also adjusting based on the motion. And on the other side, you can see the fluoroscopic KV images that we acquired during treatment. So out of this 17 patients, we saw no grade 2 toxicity. There was no migration of any of the lesions. We tracked all 3 transponders in the large majority of patients, and we saw quite small surrogacy uncertainties. And this was independent of the motion amplitude and the distance from the lesion, which was quite an interesting thing to see. So for all of the patients, we have data shown here plotting the difference in surrogacy of the fiducial to the lesion that we painstakingly measured via visual inspection across all of the patients. We also looked at the targeting accuracy of MLC tracking. So in this case, you can see in the video, we have the tumor motion is the star, and then the center of mass delivered is the white circle. So it is following the star around quite closely there. So across a population, we saw the accuracy was 0 plus or minus 1.4 millimeters. For different patients, we saw the performance of the tracking being better or worse. So the best was with a 95% confidence of 0.3 millimeters, and the worst was 2.5. We're able to plot the beam target alignment error. So if we reflect on the dosimetric accuracy of the treatment, we were reconstructing the delivered dose for the MLC tracking as well as for the ITV-based simulated treatment. So for our cohort, we saw large reductions in the PTV, on average 27% reduction in the PTV volume, but as large as 47%. The GTV dose was delivered accurately. We saw a reduction in the V20 lung dose and the mean lung dose as well. So if we look across these dose metrics, we can see broad agreement between the MLC tracking dose, this is for the target, and ITV-based plan. If we look at individual cases, though, what we find is a couple of things. So if we're looking at the dose distributions here, the red box shows the planned MLC tracking dose and the delivered MLC tracking dose. If we compare that to inside the blue rectangle, the planned ITV is starting off with a larger dose distribution because we have an ITV there. And then if we look at the ITV dose cloud delivered, then it is a little bit different to the red contour. And then examining the target coverage in the DVH, this is a little bit different to what you'd normally see. So the dashed lines are the per fraction DVHs, and the solid lines are the totals. So the red we can see is varying much less than the blue. So the blue day to day shows a large variation in the target coverage, whereas the red was more consistent. And then if we look back at the MLC tracking workflow, the simulation itself was taking about 30 minutes. We had an automated planning system, the KBP. So that was taking about 20 minutes to conduct that part of the treatment planning. We put a lot of time into the quality assurance. For a commercial system, that might not be there. And then we treated automated treatment, 15 minutes it took for the treatment. So we do need to do some quality assurance. And if we look across the extensive experience with the CyberKnife synchrony and multi-leaf collimator tracking, there's now a task group report from the AAPM on multi-leaf collimating, which covers an example of a quality assurance program. There are two sort of main pieces. So the system integrity, understanding with end-to-end tests with hidden targets and known motions, and evaluating whether the system tracks accurately, and also understanding the latency, so the time it takes for motion correction to occur inside your software, inside your system. And then there's quality assurance that occurs during the time of delivery. So this might be checking with interlocks to make sure that the target is inside a certain motion range, or whether there's a communication errors or the like. There's also potential for EPID-based systems. And then one of the things that we really lent on heavily in our research study was a dose reconstruction. So using the log files and the known motion to reconstruct our best estimate of the delivered dose. So the future outlook for multi-leaf collimated tracking is that there are a number of emerging technologies that would harmonize well with this. So there's faster data processing. There are some new algorithms. The emergence of artificial intelligence for automation, bridging gaps where we have less information is now something that is quite commonly solved using machine learning techniques. There's a evolution away from geometric margins, which we might see in the future, towards probabilistic margins, and that would synchronize well with having a real-time shape of the aperture. There's more examples later on in today's session on real-time dose prediction and dose-guided therapy and real-time functional therapy. So in summary, real-time adaptation's been available for quite a while. Commercially, tracking's been available in the CyberKnife system for 20 years. Currently, we are still implementing the first generation, which is an adaptation to rigid motion of a target. What we want to do in the future is to be able to adapt to minimize dose to OAR as well, which algorithms can do. They just haven't been implemented that way to date. MRI Linux could help with that. And real-time adaptation is very well aligned with the emerging technologies. The next generations of real-time adaptation will look at deforming an anatomy, and we'll see a bit of that next, and also looking at dose and biology guidance. We'll look into that, some of the next slides as well. Thank you. Thank you for your time.
Great. Thank you very much, Jeremy. One of the, I guess one of the questions also is, you touched on briefly, is about the workload and for quality assurance. And would you expect the quality assurance for multi-leaf collimator tracking to reduce as time goes and experience increases?
Absolutely. So we had a research system implemented at our institution. It was the first one in the world. So we took great care and went over the top, if you like, doing everything 3 ways. So if we had a commercial system, I think we would fall back on with the same way that most QA has fallen, such that we do commissioning tests, and then we do monthly QA, and the patient-specific load would be greatly reduced down to almost 0. With a commercial system, there might be more feedback between the system and the log files for real-time sort of interlocks, which we had to do some of that manually in the research implementation. So.
Yeah, I mean, thank you. And I think if we are talking about, making technology more widely available, then the automation of the and efficiency of the QA processes are sort of part of that overall package. So thank you very much.
Thank you.
We might I might move on. The 4th speaker in our session today is Dr. Emily Hewson. She is a postdoctoral research associate at the Imagex Institute at the University of Sydney, and her research focuses on MLC tracking and developing methods for real-time motion monitoring on standard linear accelerators. So very much in the theme of democratizing radiation therapy and looking at advanced applications. So her title today is Advanced MLC Tracking Applications. So Emily, Jeremy, thank you.
Yeah, thanks for that introduction, Paul. As Paul mentioned, my talk is titled Advanced MLC Tracking Applications. So I'm just going to be covering some of the more recent research that's been going on in the MLC tracking space that's gone beyond what's been implemented clinically up until now. So just a quick disclosure. So as Jeremy and Paul have already discussed in their talks, we have seen MLC tracking successfully implemented on standard linear accelerators, and it's been used for both lung cancer and prostate cancer treatments in clinical settings. Our previous work with MLC tracking has also demonstrated that it can be implemented on MLC heads developed by both of the major vendors, so both Varian and Elekta have the potential to have MLC tracking implemented, which really shows its potential for widespread use. However, what we've done up until now with MLC tracking has mostly focused on correcting for target translation as we observe it in the beam's eye view. So just a quick recap of how MLC tracking works. If we have a planned aperture shown here in black, that's tracking a target that undergoes motion indicated by the green arrow. We want to calculate an adapted aperture shown here in red, which is essentially a shape of the planned aperture, but now translated to the new target's position. However, we know that translation isn't telling the whole story of what's going on during treatment. So a lot of our more recent MLC tracking research has been looking to extend this to be able to account for other anatomical changes. So one of the anatomical changes that isn't typically corrected actively during standard treatments is rotation. So we do know for targets such as the prostate or in the liver, we can observe fairly large rotation of up to even more than 15 degrees. And this does result in loss of dose coverage to the PTV where we're no longer delivering our prescription dose. So this loss in dose coverage can vary depending on how spherical our targets are. But typically in standard treatment, we have to expand our PTV margins to ensure that the loss in dose coverage doesn't also affect the GTV and CTVs, which isn't the ideal way to be managing motion. So we can use MLC tracking to adapt to this rotation. So if we have a motion signal in real time that's giving us 6 degrees of freedom information, we can correct for both rotation in addition to translation using our MLC leads. So I have an illustration up here of how this rotation MLC tracking works. So essentially, when we plan a treatment, we have a certain aperture shape. So we can determine this shape and then rotate it by the amount of rotation that we've observed in the target, and then calculate the MLC lead position that will give us this rotated shape. So here's some example images from an experimental implementation of this. So you can see how the MLC aperture gets rotated to match the rotation of the target. So note that it's not the collimator that's rotating in these images, it's actually the MLC lead positions that are recreating these rotated shapes. So through this rotational MLC tracking, they found that the accuracy could be aligned to the target within a degree. Another form of motion that doesn't typically get corrected for is deformation. So with treatment, we have our planned MLC apertures and then deliver the same MLC aperture shape during treatment, but we know that the target itself can be changing shape throughout that treatment. So here's an example of a prostate where one of the red outlines shows the prostate's shape at a single point in time, while the other red outline is showing the prostate's motion throughout the course of the video. So I should note that this video is sped up. However, you can see how there can be quite a large discrepancy between the two contours. And so this is something particularly concerning for somewhere such as the prostate, where a lot of the deformation is a result of the organs at rest actually pushing up against it. So we're really at risk of over-irradiating those targets. So again, we can use MLC tracking to correct for this. So we can actually deform the planned aperture shape according to the deformation we're observing in the target. So this really highlights one of the advantages we can get with MLC tracking, where we have the freedom to actually reshape the radiation field as we're delivering it to correct for this motion. So these are two examples of deformation MLC tracking being experimentally implemented. So you can see if we have a deformation vector field of what the target is undergoing throughout the treatment, we can relay this information to the MLC controller to also deform the aperture shape to match to that target accordingly. So one of the main challenges in performing deformation tracking on a standard linear accelerator is actually being able to image this deformation and get that real-time anatomical information. So this can be also implemented on something like an MRI linac, where you're getting that high quality soft tissue imaging to allow us to get this anatomical information. Another complex geometry that we are interested in being able to track is when we have multiple targets that need to be treated. So for patients who have locally advanced cancer or oligometastases, they have multiple tumors that need to be irradiated together in the same course of treatment. However, the problem with this is that we do get large differential motion between these targets. So if we have a look at the example in the corner here, you can see how if we have one target undergoing motion larger than the other, you can't correct for this kind of motion by simply rigidly shifting the aperture or by shifting the patient. And so we can't correct for both targets simultaneously without compromising the coverage to the other. So Again, this is another advantage we have with MLC tracking, is we can actually use the MLC leaves to adapt to motion, even if they're in opposite directions. So this is something that's, again, unique to MLC tracking that can't be done with other motion management methods that are currently available. And it is really important that we are able to adapt to these patients who have multiple targets. So as Paul and Jeremy gave some overview of, we can see the significant dosimetric benefits these patients can experience when they have access to a technology that allows real-time adaptation. But if we're only able to adapt to rigid motion, then this technology is limited to a small cohort of patients who are early stage and only have the one target that needs to be treated. So we want to be able to enable multi-target tracking to open this up to a wider cohort of patients, so we can effectively double the number of patients that can actually receive this sort of treatment and receive these benefits, particularly as these patients have limited options, typically requiring large margins, which isn't the ideal way to treat them. So we have looked at developing a multi-target MLC tracking method. So I'll describe one of the methods here. So if we consider an example of a locally advanced prostate cancer patient who has both a prostate and lymph nodes that require treatment, we see that the prostate can undergo motion while the lymph nodes remain approximately static. So we use an algorithm that works in 3 steps. Our first step involves pre-processing before treatment. We have a look at the MLC apertures from the plan, and in the beam's eye view, we can determine which part of the aperture is covering which target and divide it into different sections accordingly. So here we have an example where you can see the red section is the part of the aperture that's covering the lymph nodes, while the blue section is the part of the aperture that's covering the prostate. And we do this so that during treatment, when we do observe motion in one of the targets, we can then shift that section of the aperture accordingly to match that target's motion. And then we recombine those aperture sections back into a deliverable adapted aperture once we take into account the physical MLC leaf constraints. So you can see here what we've resulted in is an MLC aperture where one section's been adapted independently for the prostate, while the other aperture for the lymph nodes has remained as it was. So we have tested this method through simulations, so simulated treatments of locally advanced prostate cancer patients. And we compared it to our previously used single target tracking, which involved rigidly shifting the MLC aperture according to the motion, and also compared to no tracking, which was the standard of care where no real-time motion was adapted to. So we did see that multi-target tracking was able to reduce the overall error for the targets compared to the previous methods. We also did implement this experimentally on a linear accelerator. So this is the same clinic, the variant trilogy that Jeremy has mentioned. So we did implement this and demonstrate that it was feasible. And again, we got the reduced dose error overall for multi-target tracking. So we were able to adapt to the targets independently. And we also demonstrated that I was able to perform this adaptation on a latency that was within a second, which is the bar we would aim for when performing prostate adaptation. So here I have a video showing multi-target MLC tracking in action. So you can see here, if we have 2 ball phantoms that are moving in opposite directions, we can image the targets and then send this information to the MLC controller to adapt the MLC leaves to each target's motion. So you can see here how we're adapting the different parts of the aperture independently for each target. So this particular video was taken on an MRI linac, but the same principle applies for application on a standard linear accelerator. There are some limitations with multi-target MLC tracking. So in particular, we have some complexities when we have targets that overlap in our beam's eye view. So we're still limited with what can be physically achieved with an MLC leaf collimator, where of course we're working with just pairs of leaves that can either open or close. So there are some difficulties when we have these two targets that move relatively to each other but are so close in space. We also get some complication when one of the MLC aperture sections that belongs to one of the targets is also covering the other target, so that when we do perform that independent adaptation, the other target that's inadvertently covering can receive a dose that isn't ideal. And this can result in overdosing to the target. So if you look compared to the original planned dose and the reconstructed dose when multi-target tracking was used, you can see we've resulted in some overdosing to the target, in particular near to where the lymph nodes are. So we might not be necessarily too concerned about overdosing a target. However, of course, since the organs at risk also are quite close to this space, we do end up in overdosing to those organs at risk as well. Another technique that can be used for MLC tracking is to actually combine it with other real-time adaptation methods. So one of the main limitations that we have with MLC tracking is that we of course are working with finite MLC leaf width. So all of the motion that occurs perpendicular to the MLC leaves can't necessarily be corrected for, since we're again just working with MLC leaves that can either open or close. So you can see this illustrated here, where if we have in yellow the MLC aperture that we want to form, but we can only form the aperture shown in gray, and you can see that there's some gaps, and there'll be overdosing and underdosing in our target. So one of the ways we can address this is by combining it with real-time couch tracking. So this is where we actively move the couch during treatment to compensate for any of the motion that we're seeing in the patient. So we can use real-time couch tracking to correct for all of the motion that's occurring perpendicular to the MLC leaves, and this is helpful because the resolution at which the couch can be shifted is smaller than the width of an MLC leaf. And then we can use MLC tracking to then correct for the remaining errors that are occurring parallel to the MLC leaf direction. So this has been implemented experimentally. It has been shown that performing this hybrid strategy can reduce the tracking errors compared to using MLC tracking alone. So the next work in MLC tracking is actually looking to move away from this, what we call geometry guided tracking, where we're looking at motion in the beam's eye view and trying to move the aperture accordingly. And what we actually want to do is use a dose guided method where we're adapting the MLC leaves to deliver the dose we want. So in doing so, we hope that we can eliminate some of the limitations with limited speeds and widths of the leaf, and also overcome some of the limitations we've been seeing with multi-target tracking so far. So to sum up how geometry guided tracking works, is we essentially have a 2D fluence that's generated by a planned aperture, so that during treatment we want to recreate this fluence in the new target's position. But as I mentioned, this does have its own limitations resulting from the physical limitations of the MLC leaves. So we end up overdosing and underdosing certain parts of the anatomy. And the problem with how MLC tracking has worked so far is when we do accumulate these errors, they have been ignored. So every time we've adapted an MLC leaf aperture, we've just done it for that single point in time for what's best at that point of treatment. So instead, we want to be able to actually keep track of where have we overdosed, where have we underdosed, and then fit our MLC leaves in a way that can minimize this dose error to give us a dose that's as close to the plan as possible. So to be able to do this, we need to be able to accumulate the dose to give us an idea of what we want to deliver according to the plan and what we have delivered so far during treatment with the motion. So we need a method that can give us an approximate dose calculation fast enough to be performed in real time. We can then shift the accumulated dose by the observed motion to give us an idea of what dose we actually want to deliver. And if we look at the dose difference between what we have delivered and what we want to deliver at that point in treatment, we can get this map of where's been underdosed and where's been overdosed, and we can use a cost optimization function to actually be able to place those MLC leaves in a way that minimizes the areas of overdose and underdose. So we're correcting for these errors in real time as we go. So this technique has been used in simulated prostate cancer treatments. So here are the plotted dose errors where dose-guided MLC tracking is in red. Blue shows the previously used geometric tracking, and green is with no real-time motion adaptation. So you can see how this method was successful in reducing the dose error that we're getting to the patient using dose-guided tracking. We've also looked to extend this dose-guided method to be able to also adapt to multiple targets. So the main difference in trying to adapt to more than one target is that when we are creating this dose volume that we're using to accumulate the doses, we actually create volumes that are based on the actual contours of the targets we're interested in, which we can take from the treatment plan, so that during treatment, we can accumulate the dose to these volumes and then simulate the motion by independently shifting different dose volumes relative to each other to give us that dose that we want to deliver, but with relative target motion. So again, we can optimize the MLC leaves in a way that minimizes the overdose and underdose, use this to update what we've delivered, and then repeat this process until the end of treatment. So this is also used for simulated treatments, but looking at locally advanced prostate cancer patients. And so again, you can see that we have the lowest dose errors when using dose-guided MLC tracking. So we're seeing a lot of promising results with using a method like this in helping us minimize the dose error that we're actually delivering during treatment. Another advantage to using a technique like dose-guided MLC tracking is that we can really specify where we want to deliver the dose and where we want to avoid delivering doses. So with the previous MLC tracking methods, what we essentially were aiming to do was to recreate an MLC aperture that would deliver a dose that's as close to the plan as possible, but it would treat all dose errors the same. Whereas, you know, if we're underdosing an organ at risk, for example, we're not actually concerned with that sort of dose error. So with something like dose-guided tracking, we can have a look at the dose volume we're accumulating in and label it according to where the different targets are compared to the organs at risk, and use this information to further penalize any overdosing we're seeing to the organs at risk, as opposed to when we see an overdose, for example, to the target. So this is really giving us that flexibility to sort of customize how we're delivering the dose and considers the anatomy that we're actually seeing at the treatment, rather than trying to recreate the plan, which is based on anatomy that we're not actually seeing during treatment. So just to summarize the main points, so MLC tracking can enable real-time adaptation without the need for additional equipment. So we're using software rather than a specialized system. And MLC tracking is capable of correcting for a variety of types of motion, including types of motion that can't actually be adapted to using other methods. So for example, with deformation or when there are multiple independently moving targets. And the next generation of MLC tracking is going to be looking at optimizing for 3D dose errors to create do replanning in real time, essentially. So really minimizing those dose errors. But I should also note that any MLC tracking technique that you want to implement also requires some kind of real-time signal giving us that information of the anatomy, whether that be the different types of motion or an accumulated dose or even functional information. So that's another aspect that needs to be considered when implementing this on a standard linear accelerator. So in Chandrima's talk, she covered a few techniques we can use, and in the next talk, Maegan will also discuss a few more techniques that can be used to guide MLC tracking. Yeah, and thank you for your time.
Great. Thank you very much, Emily. And yeah, I think this is a good segue into the next presentation, because the MLC tracking is very advanced, and to make this really widely available, we need a widely available motion signal, and a lot of the work that's been discussed previously has been looking at markers. So the final presentation of this session is markerless tracking for lung SABR, and that will be presented by Dr. Maegan Gargett. Maegan's a medical physicist at the Northern Sydney Cancer Centre and a clinical lecturer at the University of Sydney. And she's currently performing real-time motion adaptation research and including applications for dose guidance in radiation therapy. So yeah, we look forward to learning more about markerless tracking. Maegan.
Thanks very much, Paul. And thank you to the organisers for the invitation to present today. So just a quick disclosure before I start. I am listed as an inventor on the IP associated with some of the software I'll be talking about today. So taking an appropriate motion management approach during radiotherapy is crucial, particularly for lung stereotactic ablative approaches, where there's a requirement for high accuracy and the motion is dynamic and complex and can vary quite unpredictably. Planning for lung SBRT will generally involve the acquisition of a 4D CT to obtain patient-specific motion information. However, there are publications which suggest that motion captured during the 4D CT is underestimated compared to the motion observed during treatment delivery. That's due to motion amplitude variabilities and the presence of baseline drifts. So this increases the value in being able to monitor breathing pattern changes and possible baseline drifts during treatment and correct for such deviations in real time. The most common tools at our disposal for motion management are based on surrogates for tumour motion, including external surrogates such as marker blocks to infer tumour position, as well as internal surrogates such as electromagnetic beacons and monitoring fiducial markers in kilovoltage imaging. But I think it's arguable that none of these systems quite meet what we would consider to be the optimal solution for real-time target monitoring, which would be to achieve a 3D internal monitoring that's accurate, that's able to be achieved in a cost-effective manner, both in financial terms and in terms of patient experience, as well as being accessible. There's been significant technological advancement to move us towards the goal of real-time monitoring, where we see what we treat as we treat. And one such advancement is towards markerless tumour tracking. So markerless tumour tracking is defined as a real-time target position monitoring system where the target's tracked directly in intrafaction imaging as opposed to marker-based tracking. And it can be used in complement to motion management approaches which aim to restrict motion, such as breath hold techniques, or as an input for gating or tracking applications such as MLC and couch tracking. There are existing implementations of markerless tracking in both preclinical settings and commercial systems, which started with specialized systems utilizing KV imaging to update motion correlation models for target localization, then adaptation. Development has now reached particle therapy and MR-Linac machines, as well as conventional Linacs. And if this development continues, it has the potential to become the standard of care in respiratory motion management approaches. A few years ago, an AAPM Grand Challenge called Match was run, where participants used a common methodology to benchmark their markerless lung tracking algorithms. And an overview of the challenge design is shown in this diagram. So it had two parts. In the in silico study, participants tested their algorithms on intrafaction imaging provided for simulated lung SBRT treatments. And then in the phantom study, the participants used a common anthropomorphic thorax phantom on a motion platform and used their algorithm prospectively to track lung lesions for a set of provided motion traces. The results of the challenge have been published with several systems able to achieve sub-millimeter accuracy and precision. And the in silico data and experimental method is available for others to follow when testing new algorithms. I'm now going to go into some detail on the MAGIC software, which is a markerless tracking software developed by researchers at ImageX, and the workflow of which is shown in this diagram. So it's an example of a markerless tracking method that's been implemented on a traditional C-arm Linac utilizing KV fluoroscopic imaging. And later I'll also discuss a little bit about how we approached the commissioning of the software for a clinical trial which we're running at my department, in which we're feasibility testing the software in an observation-only study. So to start, during the planning stage of the patient's course of treatment, the simulation 4D CT is used to create a patient-specific template library of the target and a correlated diaphragm motion model, which will be applied at the time of treatment. At the beginning of each treatment fraction, a learning cone beam CT is acquired, where that model is updated for motion of the day. And we also construct a function which is used to transform the 2D tumour position into a 3D position. And there's also a 1D surface signal from a depth camera, which is used as an input for the purpose of regularization. So during treatment, we collect KV fluoroscopic imaging to be used as the tracking input. Each incoming KV frame undergoes some pre-processing. Then the tumour position is calculated and reported as a 3D position in the software interface. That process repeats for all frames as they're acquired, so giving us a real-time tumour position during treatment. The ValKim trial has been designed to evaluate the feasibility of this markerless lung tumour tracking software. It's a single institution observation-only trial running at the Northern Sydney Cancer Centre, with the patient selection criteria shown in this diagram on the right. And the goal of the trial is to establish whether the implementation of the proposed technology is feasible in a real clinical scenario, to assess whether it'll be safe to implement and whether it assists the clinical workflow, and also to look at whether the users are confident in its utility to an extent that it could be released for larger interventional studies. And the accuracy of the software will be compared against implanted fiducial markers as the ground truth in the trial. So I'll share a little about how we approached commissioning of this software before commencing the trial, which closely followed the methodology presented in the match challenge. We incorporated tests from what other guidance documents we could, some are shown here, drawing on experience with marker-based approaches such as KIM and some non-radiographic localization advice provided in TG147. So we aim to emulate our lung SBRT procedure during testing as closely as possible. We had access to a 3D printed anthropomorphic phantom, which included mock lung tumours, which was really valuable given that we wanted to validate the software with an imaging input as close as we could get to clinical imaging. So the phantom was set up on a motion platform and allowed us to perform dynamic testing. So we acquired 4D CTs with the phantom and created a treatment plan for each of the motion traces we used for testing. We evaluated tracking accuracy under both static and dynamic conditions with the dynamic test cases created using patient representative motion traces, which are shown here. And they were taken from what was used for the match challenge. We calculated the tracking accuracy relative to the program trace and also to the motion traces obtained from fiducial markers, which we placed in the phantom to mimic the trial analysis we would perform. Latency of the system is also an important consideration for real-time use, so that was considered as well. We also performed some limitation and failure mode testing to stress test the system, if you like. So we tested things like the impact of a deviation in target motion from the 4D CT modeled motion, and what would happen if we lost communications as well. So I'll briefly show some of our commissioning results. So I'm showing a screen recording of the software interface on the bottom right. And then on the left, we have some plots comparing the markerless tracking in red against the marker tracking in blue and the programmed motion trace in black. Our commissioning tests showed dynamic tracking accuracy and precision within 2 millimeters for all of our test cases, and that the tracking errors were less than 3 millimeters for more than 80% of the treatment, which is the feasibility criteria for the trial. And the computation time was also acceptable for real-time use, being less than 500 milliseconds. Markerless tracking's potential as a cost-effective and accessible approach to motion management doesn't stop at lung and respiratory motion monitoring. Future avenues of development, which ImageX are progressing with, are to extend to other tumour sites, as well as inclusion of organ at risk monitoring to complement tumour tracking, which I'll briefly touch on in the next slides. So there's a project looking at monitoring the position of vertebra during spine SBRT treatment. As we know, a high degree of targeting accuracy is critical for those treatments, and often we'll take repeat cone beam imaging to verify the patient position during treatment. But tracking the vertebra directly during treatment would allow for continuous motion monitoring, and potentially staff could intervene earlier without needing to pause treatment, or we're not waiting for a predefined imaging time point to correct for any change in position. So it could be a valuable application there as well. For head and neck treatment sites, a potential application of markerless tracking would be to implement it as a verification tool to provide safe and effective radiotherapy for head and neck patients without the need for immobilization masks. So this would improve patient experience and comfort during treatment by relying less on immobilization masks for fixation and tracking the tumour position using KV images acquired during treatment. So in the image on the bottom right, you can see an example of the performance of a network trained to segment the GTV position in treatment imaging. There's also development work for abdominal targets to be monitored in intrafraction imaging. Models are being built for prostate, pancreas, and liver targets. And these present a challenging scenario given the absence of high contrast features to track for these sites. They're also typical SBRT sites where motion management strategies are crucial. So patients will typically have fiducial markers implanted for monitoring, which is an invasive procedure. And depending on the treatment site, there may be a great deal of difficulty implanting the markers in a suitable location for tracking, and some patients can be excluded due to contraindications. For this site as well, there is, as you can see in this diagram, a pathway for real-time tracking has been proposed, where the treatment is adapted in response to target motion. But this is still in the early developmental stages. This is an example of prostate segmentation performed by a deep learning model. The first two rows of figures show the 2D tracking accuracy for two different treatment fractions, and the last two rows show the tracking error, here defined as the difference from the ground truth, and the dissimilarity to the ground truth in the bottom row. The tracking errors are largely within 2 millimeters, and the contour similarity metric is high as well. Similarly, this shows an example for a pancreas target, arguably the most challenging case. Here, the tracking errors are on average closer to 5 millimeters, and the dice score a little poorer than for the prostate, but still quite promising for an initial study. There's also work being done for liver SBRT patients who have previously undergone TACE chemotherapy. An observational feasibility study is being run across a few Australian centres to evaluate whether the radio-opaque contrast agents that are left behind from TACE can be detected in patient imaging by tumour tracking software as a surrogate for the notoriously difficult to visualise liver targets. And lastly, another area of research is into multiple target tracking, which is a concept whereby the target as well as key organs at risk are segmented in real time. So this example shows a lung tumour and the heart being segmented simultaneously, with the plots indicating tracking accuracy against a ground truth shown by the blue line. The position of organs at risk is an important consideration, especially when they're in close proximity to the target with potential ill side effects to the patient if we blindly track the target alone, as Emily spoke about. So knowing the OAR position could help widen the therapeutic window for these patients and help us make more considered treatment adaptation decisions. In summary, research performed into markerless tracking shows it to be a promising real-time image guidance technology. There's substantial advantage to its approach, particularly its non-invasive nature that doesn't require extra procedures for the patient that carry associated risks and require extra resources. In the few examples I've presented from our group, all are based on imaging collected on a standard C-arm LINAC, and other groups such as VU Medical Centre in the Netherlands have also demonstrated this as well, this markerless tracking on a conventional LINAC. So it shows it has the potential to be widely accessed through a software-based solution in conjunction with existing hardware. The feasibility is being evaluated in clinical trials, both currently and in recruitment or in design. And to further refine the approach and hopefully arrive at a workflow that can ultimately improve treatment efficacy for our patients. Thank you.
Great. Thank you very much, Maegan, and very nice to finish off on markerless tracking, because if we are looking at making this technology widely available, that obviously markerless is a key part of that. You showed some of the work that you've done with with phantoms and like sort of motion phantoms and complex phantoms. How do you see this technology being deployed or accepted in clinics as the technology matures?
Yeah, that's a good question. I think given that this was sort of the first trial which we're looking at the markerless tracking for, we did really want to have that as lifelike as possible and anatomically accurate as possible phantom to look at before we progress to patient treatments. And I think that will be true of other treatment sites as well. But once the algorithms are validated, ultimately they should be able to be rolled out, I would think, by, I guess it won't rely as much on those phantoms once it's all been benchmarked. So I think it would be possible for other centres who perhaps don't have access to those phantoms to use other alternatives for their commissioning.
Great, thank you. Professor Chougule, do you have some questions?
Yeah, most of the questions which have been put into the chat box have been answered. Also, the speakers were so smart that they have written down the answers in the chat box. But just I want to know that any technology created or improved or any software or add-on facility which is coming up, do we need to, for validation, clinical trials are required? Are they mandatory? If yes, it should be a multicentric clinical trial so that the technology or the gadget comes into clinical application.
Thank you, and the others are welcome to. Other speakers are welcome to add, but maybe I will start. So in radiation oncology, to get devices approved, there's a much lower barrier for devices than there are for example, for chemotherapy drugs, where human trials are absolutely required. There are very few innovations in radiation therapy where clinical trials have been required, and so most of the technology we have does not require clinical trials prior to broad validation. Examples being IMRT, VMAT, respiratory gating, and we also don't need the randomized clinical trials. So in some ways, that's it makes things easier to be approved, but it also we don't have that strength of evidence of the benefit of the technologies that a drug trial has. So there aren't that many randomized trials of technology to be able to say how much benefit a patient, how much benefit a patient cohort will have. Maybe Jeremy or others, do you want to?
Yeah, because for other drug, pharmaceutical, or any other devices we use in cardiology or any other specialty, there are because I am involved with the clinical trials, so I know very stringent methodologies, and then the long-term post-marketing surveys and all these are done. But as far as I know about the radiotherapy equipment or gadgets, yes, we do validation or QA/QC, but not mandating clinical trials and the outcome benefits and testing assessment is not mandatory to my knowledge.
Yes, yeah, that's my understanding too, though. As you say, things that are implanted into humans, such as you say, cardiac stents. Also, there was a technology, Calypso, which was implanting larger beacons into patients. The US FDA required them to do a clinical trial to demonstrate the biocompatibility. So there are some examples in radiation oncology of clinical trials, but not that many that are required for approval.
But when you develop a technology or equipment, that has to get approved from, for example, European Union, you have concluded that it should be approved. So when the MR-Linac has come, it got approved into the European market and then to US market. So different agencies which give you the approval for those and registered those equipment or technology, right?
Yes. And I think as developers of new technology, particularly in a university or hospital setting, all we can do is develop the technology and take that to clinical trials. If we want to go beyond clinical trials, then a vendor needs to take that technology and go through US, FDA, EU certification, so that's something that's beyond a university or a hospital.
So when you transfer the technology to a company which is going to manufacture, then they will go to the agencies, FDA or CA, and then they will get the approval, right?
Correct. Yes. Yes.
So I could see there are no questions into the chat box. Already discussions had taken place. So I will like to thank you particularly for making this AFOMP school to happen. And always, as the president of AFOMP or chair of the EPC, I am trying to convince the medical physics students or even it's not just working into radiotherapy or nuclear medicine testing. They can contribute into technology development, technology testing, and how it can happen. So there's ample scope in research and the development of the technology, and that your group is doing a marvelous job. So thanks to you, Dr. Chandrima, Jeremy, Emily, and Maegan, for sparing their valuable time, actual experience, involvement into the development of the technology, and that what rightly you have said is it should be affordable. Whatever technology I will, by add-on doing this thing, can you track the motion management? Can you improve the treatment rather than costing huge amount to the patient or the disease system? That is a very good thing you are doing, and it's nice to see that your group is a lot of patents you have got, and then negotiating with the company. So the technology developed actually doesn't remain into the lab, but it come to the actually bed to the patient benefit. That's thank you very much. So thank each one of you for your contribution and time sparing. Thanks to all the attendees, participants for joining into the discussions also, and to the chair education training committee the chair PRC, Chai Hong, Rajini Verma, and all who involved from AFOMP to make this AFOMP school webinar to happen. And as I told you, that is a continuous process, and this is the AFOMP has taken that how we can help in educating our professionals. And in this series, we have the 29th monthly webinar scheduled on 6th October during 7 to 8 a.m. GMT, and that is on current status and future direction of proton therapy physics point of view, and this will be given by Professor Han from Seoul, and this will be moderated by Dr. Arvind Shukla. So already the information is on the AFOMP website. Please do visit, get registered. Similarly, as you know, that AOCMP, AFOMP, has annual conferences, and 22nd Asia Oceania Congress of Medical Physics 2022 is being held in Taipei, Taiwan during December 10 to 12, and it will be in hybrid mode, in person, and also virtually you can join. The organizers are trying their level best, and we are expecting the 3-day quarantine will go away as time passes, and we will be able to meet in person. As AFOMP is taking a lot of interest, and we have instituted a lot of awards, the information is on the AFOMP website. So please take advantage of the AFOMP educational and training activities, and any queries, questions, suggestions are there. You are free to provide to me so that we will try to improve to your expectation. Once again, I thank Professor Keall, his entire team, for sparing time and giving insight into actual research being carried out, and that's the technology this thing. So thank you very much, and on behalf of the AFOMP, we thank you all for sparing your time to the participant everyone. So have a nice time, and I will be there chasing you for some other programs so that our colleagues, they get benefited. So thank you each one of you.
Thank you very much on behalf of our entire team, and yeah, good night.
Have a great day.